Hi, everybody. Welcome back. So for lecture 13, we're going to be reviewing chapter 9, which is compatibility testing. So let's look at our objectives first. So we will define compatibility testing and cross-matching. We will list procedures that are included in routine compatibility testing and explain their purpose. We will discuss the selection of cross-match compatible whole blood, red blood cells, plasma, platelets, and cryoprecipitate for transfusion. Discuss limitations of cross-matching. Describe how cross-matching is handled in the case of a massive transfusion situation. And discuss the advantages and issues related to computer cross-matching. We will also explain when immediate spin, computer, and antiglobulin cross-match techniques would be performed, explain the elements of patient identification and their importance in compatibility testing, explain the use of a maximum surgical blood order schedule, and explain how compatibility testing would be carried out on an infant younger than 4 months. So let's get into our information. So compatibility testing is a terminology we use to describe all of the steps in the identification and testing of a donor unit and a proposed recipient's blood, okay? So we're basically doing testing on the person who's going to receive the transfusion. They are called the recipient, and whatever donor unit they are getting, most often this is donor red cells. Cross-matching specifically is a very important part of compatibility testing, and for the cross-match test, we take some of the donor unit red blood cells that we're thinking of transfusing into the recipient, and we don't enter the whole blood donor bag. We actually use something called a segment that is attached to the unit, and we'll be looking at pictures of what these segments look like in a minute. And we make our 3 to 5% red cell suspension from the segment of the donor red cells, and then we test them with the recipient's serum or plasma. So remember, recipient is the person who we're thinking of transfusing this unit into. Just a word about the segments. If you ever had an opportunity to donate a unit of blood at the Red Cross or another blood donor center, you would know this. And some of you I know have not had that opportunity. But when they are collecting the unit of the blood, it's in a bag. Okay, we're going to be looking more carefully at this in exam 4 material. But basically, exam 3 material. But basically, after the donation is completed, the sterile tubing that the blood was flowing through from the donor's arm to deliver their blood into the unit, the bag, is clamped off and sealed, and that's what we get the segments from. So the segments really arise from the tubing that the donor's blood was flowing through to reach the collection bag. And we'll look at a picture in a moment. So when we're doing our cross-match testing and we're mixing our recipient serum or plasma with the donor red cells, if we do not see agglutination or hemolysis, this indicates compatibility, meaning it looks like these cells would be okay to transfuse into this recipient. If we get agglutination or hemolysis, remember this indicates that possibly some antibody in the recipient's serum or plasma found a corresponding antigen on the donor red cells. This indicates incompatibility, and we would not want to transfuse this unit into the recipient if at all possible, okay? So do not transfuse. However, there's a caveat here, unless there is no other option. And so sadly, in some cases, an individual may be in dire need of a transfusion, and we may not be able to find any blood that's completely compatible with them. So there may be an instance where a physician would have to sign off on this, where they would allow a transfusion of incompatible. And this is not ABO incompatible. Okay, this would be to one of those other blood group system antigens that we talked about before. So the purpose, cross-matching, testing the donor red cells with our recipient's serum or plasma actually serves as a double check for ABO errors. If we made a mistake in typing our recipient, this could show up in the cross-match test. We could see a positive reaction with the donor red cells. So, some ABO antibody in the recipient is reacting with the donor red cells because of an ABO incompatibility. So it's a double check on that. And this can actually help to prevent life-threatening transfusion reactions. So we always want to maximize in vivo survival of the transfused red cells. So we're really focusing here on transfusions of packed red cells. And so packed red cells, are red cells that don't have any plasma, it's not whole blood. And we learned previously that, as a review, what is the universal red cell donor? Anybody? O, type O. Rh negative would be absolute universal red cell donor. We have to remember that a patient who's getting a transfusion of one or more units of red cells is having this transfusion because they need to raise their oxygen carrying capacity, okay? And so basically the goal of 1 unit, and this is important, 1 unit of packed red cells, ideally what we want to happen is for this donor unit of red cells to raise the recipient's hematocrit by 3% or the hemoglobin by 1 gram per deciliter. So here's where we have a flashback to hematology. Remember the rule of 3 we talk about in hematology? Remember how we could take hemoglobin times 3 and that should give us hematocrit? It's an easy way to remember this. So if you can remember that the goal of 1 unit of red cells is to raise the hemoglobin by 1, then you should know 1 times 3 is 3. So it should also raise the hematocrit by 3%. And so cross-matching provides a second means of detecting antibodies besides or in addition to the antibody screen. And we'll look at some situations a little bit later where sometimes antibody screen might be negative, but the cross-match it can be positive. Okay? So according to the American Association of Blood Bank Standards, cross-matching, quote, shall use methods that demonstrate ABO incompatibility and clinically significant antibodies to red cell antigens and shall include an antiglobulin phase. This is a nice table, or a flow chart, I should say, from our textbook that really outlines the entire process of a transfusion, and it's very, very detailed, okay? So of course, the identity of the recipient should be confirmed. And so this is part of the phlebotomist. They collect a sample from the recipient and label it. And so we learned in 102 how oftentimes clinical sites will use an additional means of identification to make sure it's accurate on that recipient. So the blood arrives in the blood bank, which is also known as transfusion service, and they're going to be doing some testing on this recipient. So they're going to review to see if they've been to our institution before, and if so, do they have an ABO and Rh type, and have they had a previous antibody screen? Okay, so they will most often do this testing on the new sample as well. Okay, so donor units come into the hospital usually from a blood donor center like the Red Cross. And so we'll be talking a lot more about how this inventory is managed a little bit later. But basically each hospital blood bank has to decide how many units do I need of this ABO type, and they have to maintain an inventory in their refrigerators for all circumstances. So if you're working at a very busy trauma center where they do a lot of surgeries, or they have a lot of people that come into the emergency department with gunshot wounds, you may need to order quite a few units of different types of products, okay? And what I will say to you all is that these products are not free. So while the American Red Cross is a nonprofit agency, they pay lab techs, they pay a lot of other personnel to do the testing and deliver the products, etc. And so that cost is passed on to the consumer, who is a hospital. And a couple years ago, a basic unit of packed red cells, I think, was between $250 and $300. Now, the patient's insurance is going to pick up the tab for that, but the hospital has to pay for these, so they don't come free. Okay, so we want to cherish these units and use them appropriately and not waste them. So when the donor units that are ordered from the blood donor center, like the Red Cross, arrive in the blood bank at the hospital, they will do some confirmatory testing on the ABO and D type, and we're going to talk about when in a minute. Now, these units are tested at the blood donor center, and here's the testing that's done. ABO and RH, antibody screen, and screen for infectious diseases. And so this would be our American Red Cross, and then they ship the units to the hospital per their request. But once those units arrive at the hospital, they will do some basic confirmatory testing of ABO and sometimes RH type. So they're going to select a unit for the recipient, and they want to try to use units that are going to outdate first. Okay, just like if you have some products in your refrigerator and something's going to expire first, you're going to eat that yogurt first. That hopefully that's going to expire first before one that has, you know, a couple weeks on it. And then they're going to do cross-match testing. After the cross-match is completed, they would tag the unit for the person who's going to receive the transfusion. There's a whole big process in place to identify clerical errors, etc. And so we'll be talking more about that part of it a little later. So let's talk about compatibility testing and the history of how this testing arose. So you all know Carl Landsteiner. We've talked quite a lot about him already. And Carl Landsteiner, we know, discovered the ABO system in the early 1900s. By the time 1907 came around, major and minor cross-match testing began. So the cross-match testing that we do today is the major cross-match. The major cross-match is what I described to you a few minutes ago, where we take the recipient's serum or plasma and we test it with the donor red cells we're thinking of transfusing them. The minor cross-match was the reverse of this. And the minor cross-match was really done back in these days because back when transfusions were starting, they didn't have the capability that we have today to centrifuge products and you know, take the red cells and have them separated from the patient, from the donor's plasma. Basically, when someone got a transfusion, they got a transfusion of whole blood. So it better be the same ABO type, ABO identical, right? If you're getting whole blood, you're not only getting red cell ABO antigens in that transfusion, but you're also getting ABO, naturally occurring antibodies, in the plasma that those red cells are suspended in. So the minor cross-match was taking the red cells, taking the red cells from the recipient and testing them with the plasma of the donor. It was the reverse, okay? And as I said, this was really done more so back in these older days because they were transfusing whole blood mostly. So by the 1950s, the antibody screen began. We could see that in 1976, the minor cross-match became optional. And, you know, in these later 70s and early 80s, transfusion medicine was evolving, and the science, since we had the capability to, in a sterile way, separate donor red cells from plasma and platelets, the thinking was, why are we giving patients transfusions of whole blood, because what they were finding is if somebody just needed red cells, why are we giving them all this plasma from a donor? It could put strain on someone's circulatory system, their heart and lungs. And so the thinking evolved to just give the specific type of component that a person needed. And so this minor cross match sort of fell beside the ways, so to speak. And so you will not, I guarantee you, when you go to your clinical rotation, you won't see anybody doing a minor cross match anymore. They're really not done. So in the 80s, immediate spin cross matching was instituted. And then in the 90s, with the age of technology, computer cross-matching was begun. And so we'll talk about when it would be appropriate to do each type of cross-match in a moment. So immediate spin cross-matching is kind of like how we do our ABO typing. And so remember, we're taking recipient serum or plasma. It would be 2 drops of, let's say, their plasma in a test tube if we're doing tube testing, and 1 drop of the donor 3 to 5% red cell suspension that we're thinking of transfusing to that person, and we mix everything together and we do immediate spin, centrifuge right away, and read. And that's the immediate spin cross match. It's as fast as doing our ABO forward and reverse typing. Sometimes we can have unexpected incompatibilities that show up in immediate spin cross matching. So when we started this unit today, mentioned to you guys that cross matching is a double check on ABO typing errors. And so basically we can pick up ABO phenotyping errors of our recipient. Maybe there was a patient identification error when the phlebotomist was drawing the sample, or a sample labeling error. And so when we repeat the ABO testing, it could be picked up by an incompatible cross-match, repeat ABO testing, patient looks like they changed to be a different type, need to redraw the patient. Okay, so I will tell you that one of the second-year students this year came to me and said, we had a situation when I was doing my blood bank rotation where the patient had been seen in the hospital, at the same hospital, and we had an ABO RH type on this patient, and all of a sudden we're getting ready to do a cross match on the old type, and the patient's ABO type changed. It was different. And so they redrew the patient, tried to make sure it wasn't a clerical error, and in this case what happened was the patient had a bone marrow transplant. And so when an individual has a bone marrow transplant as treatment for multiple myeloma or leukemia or some of these other serious blood disorders that we talked about in hematology, if they have an allogenic transfusion of bone marrow from someone else, their ABO type can change, because basically their bone marrow is killed with cytotoxic drugs, and they take on the identity of the bone marrow that from their donor. Okay, so that was an interesting case. Unexpected antibodies. Okay, so unexpected antibodies in our recipient can also cause some incompatibilities in immediate spin cross-matching. So let's think. What types of antibodies react best at immediate spin? Room temperature, cold, IgM, right? So if they have an ALO antibody that's class IgM, like an anti-big M or an anti-P1, or I could say anti-N, right? It's going to show up there. If we find an unexpected antibody showing up here, we'd have to try to find out what it is, okay? We could have an anti-A1 showing up in a patient who's subgroup A2. So this is a good review of ABO discrepancies. So remember when we talked before how 80% of the population who are type A are type A1, but 20% of the population is A2. And since the A1 antigen and the A2 antigen are slightly different structurally, it's entirely possible for an individual who has A2 antigen to develop an antibody against the A1. Okay, so we could Confirm this by testing with A2 cells. And then sometimes there are cold autoantibodies, antibodies directed against self. So once again, they're going to be IgM. We want to think auto anti-I, or that combo auto anti-I big H. And so we did talk about this in our unit on other blood group systems. And so remember, big I is on all adult cells. H is basically on all red cells, including cord blood cells, and so we could do testing to determine if they're clinically significant. So let's compare and contrast two different types of cross-matching. So we have already talked a little bit about immediate spin cross-matching. When would it be acceptable to do only an immediate spin cross-match? And this is very important to remember. When we have a recipient who has no evidence of an antibody now in their current sample, meaning they've had a negative antibody screen, and they have no evidence of an antibody in their history, okay, both. None current, and they've come to our hospital before and they've always had a negative antibody screen. Okay, so then it's okay to do immediate spin where we take recipient serum or plasma, 2 drops in a tube, mix with our donor red cell suspension, 3 to 5%, centrifuge immediately and read, and everything should look negative, no agglutination or hemolysis. This is fine, and it fulfills AABB standards for detecting ABO incompatibility, because if there was a mistake in ABO, remember, we do ABO testing immediate spin, it would be detected there. The antiglobulin cross-match is more labor intensive. And so when you're doing tube testing, we start with immediate spin, but this is similar to the phases of testing we do or we learned about with antibody screen and panel testing. So we do the immediate spin testing. However, we're not done. So we're going to move on to a 37-degree phase where we use a potentiator, incubate our tubes, and then we're going to read them at 37, and then we're going to wash those tubes because we're getting ready to add AHG. Okay, so the 3 phases of testing are exactly the same as the phases of testing we outlined for antibody screen and panel testing. Okay, and when are we going to have to do all 3 phases? When our patient has a clinically significant antibody, either now in their current sample or they've had one in the past. So many patients we've learned, you know, go to the same hospital, they have their physicians there, they'll come back to the same place, and so we have a record. So if my patient had an anti-Duffy B, you know, a year ago, they still have anti-Duffy B, we're going to have to do an AHG cross-match, okay? And knowing that history, or even what they have now, when we go to do a cross-match, this is a good review from last time. So let me find my pen. I like to use the Duffys. So let's say if my patient has, trying to be very neat with my writing today, I'm doing a good job so far. My patient has anti-Duffy A, okay, and we know this either now or in the past. Before I even select a unit to cross-match, we want to have it be ABO compatible, of course. However, what would we need to consider if they have anti-Duffy A? We would need to find units that only to cross-match that are Duffy A antigen negative, right? Wouldn't make sense to waste my time cross-matching units that have the Duffy A antigen, because in this case, this antibody against Duffy A would react with the donor red cells. So we have to phenotype units to find some that are Duffy A antigen negative. Okay, so if the recipient has an autoantibody, we would need to get rid of that autoantibody. You know, usually auto-absorbing with that patient's own serum. Remember, auto-absorbing, you know, the red cells are going to take out that autoantibody, and then we can look for other antibodies that might be present. Okay. Computer cross-matching is the newest one on the scene, and computer cross-matching, we learned, became important in the 90s. Took it a little while to catch on, but basically the final check of ABO compatibility is done by a computer in selecting of units instead of doing an immediate spin procedure. When could we do a computer cross-match? Some of the criteria are the same as when we can do an immediate spin cross-match. So just like IS, recipient cannot have any antibodies now or have a history of antibodies. So negative antibody screen currently and in the past. Now, an additional thing, this is different than our IS, we must have 2 separate ABO typings on file for this person, not just one. We must know their ABO RH type has been tested twice, okay, and agree before we do the computer cross-match. And so barcodes are used as a safety measure. This is felt to be a better management of inventory. So basically, there's a system of checks built into the computer. And so basically, you know, let's say I have a patient who's A positive. So the computer is going to go into the inventory. So, you know, let's say we bought our units of all of our units from the Red Cross. They all have a barcode label on them. They're scanned when they come in. So we know what's in our inventory, and what is also captured is that unit's expiration date. So the computer is going to say, okay, I'm going to look through these A positive units we have in our fridge, and I'm going to pick the one that's going to outdate first. Meaning, like if this unit's going to expire on Friday, I'd rather pick that one than pick one that's going to expire 2 weeks from now, because we don't want to waste these precious red cells. Okay, so computer does the check. So just remember, no antibody now or previously, and 2 previous ABO typings. So this is a nice chart, which basically just reviews all of the important criteria for each type of cross-match. So immediate spin, no antibodies currently or in their history. Computer, we build on that. No antibodies in current or in history, and 2 ABO determinations, and computer will validate it and match it. If we have a patient who either has an antibody now or an antibody in their history, we must do an antiglobulin cross-match with AHG. Okay, so limitations of our compatibility testing. Just because we get an acceptable cross-match, meaning negative reactions, and it looks like it's okay to transfuse, does not always guarantee that the transfusion will indeed be successful. So sometimes transfusion reactions do still occur, and they're usually not life-threatening. They're usually to antibodies of other blood group systems, not ABO. And so here's why. A negative antibody screen does not guarantee that the recipient does not have a significant antibody. Okay, why? Let's think about those antibodies to low frequency antigens like CW. Here's a blast from our past. So remember, CW is an antigen in the RH system, and most people do not have CW antigen. However, let's say we have a patient that happens to have an antibody against CW. Their antibody screen, the screening cells we use, may have also not have CW antigens, so we look like negative antibody screen. However, maybe when we pick a unit to cross-match, it just so happens the donor has CW and we get a positive cross-match. Or in this case, maybe we miss it on the donor and we get a reaction that occurs. Okay? And a compatible cross-match does not guarantee survival of red cells in vivo. So remember, we're trying to simulate in vitro in our lab testing what's going to happen in vivo, but we can't obviously simulate every aspect of the patient's immune system. So when are antibodies missed in compatibility testing? And I talked a little bit about this already. The antigen, which corresponds to the patient antibody, is not represented on our antibody screening cells. And so this was the example I gave before. The patient has an antibody to a low frequency antigen like an anti-CW. So we don't know that they have this antibody because they had a negative antibody screen. Patient has a weak antibody, which requires homozygous expression of the target antigen to be detected. Dosage, remember that? So let's say when we did our antibody screen, the screening cells that we used were heterozygous. And so here I am with my favorite Duffy's. Let's say our patient has anti-Duffy A, but the screening cell has both Duffy A and Duffy B. If their anti-Duffy A is weak, it may not have a positive reaction with this cell because it's heterozygous and not homozygous. Okay, so that's an example of how dosage can affect things. The patient antibody is detected only by using a special enhancement, which we did not use in testing. Maybe we use LynnC as our potentiator, and the patient's antibody is so weak it needs PEG, and we didn't use PEG. Or we have an unknown history of the patient. So any of those could contribute to missing some antibodies in compatibility testing. So let's move on and talk a little bit about the recipient's blood sample. So when we're drawing the recipient's blood, patient identification and sample labeling criteria, we need to have 2 independent identifiers per the AABB standards. So ID number, name, date of birth. The label and requisition must be compared to the ID bracelet, and we must have the patient state their name. And so hopefully all this makes sense to you guys after phlebotomy, when we stress the importance of not just saying to the patient, is your name John Smith? Because some people are hard of hearing, some people don't understand English well, they could be shaking their head yes, and that's not the person. So we don't want to be the person that makes that mistake. As far as sample collection tubes, EDTA, as we've already established, are the main types of samples that are drawn. It could be pink EDTA or the lavender EDTA, anticoagulated blood. And these are really good for the DAT, the direct antiglobulin test. So remember, in blood bank, plain red tubes, serum tubes with no gel, they could have a clot activator, can also be used in blood bank, but they are not ideal for a direct antiglobulin test because complement can be activated in the plain red tubes when they're stored in the refrigerator. Okay, so EDTA is really ideal. And we want to also take into consideration sample age. So we want to collect no more than 3 days within the scheduled transfusion date, and the draw date is 0. Okay, so let's say if Monday is the day we're drawing the tube, Monday would be 0, Tuesday would be 1, Wednesday would be 2, and Thursday would be day 3. We don't want to collect too far in advance. If the patient has been recently transfused or was pregnant in the past 3 months, or the history is unknown. So we really ideally want to repeat testing every 3 days. Sample collection and appearance, we've already talked about how in blood bank hemolyzed samples are not acceptable because hemolysis can indicate a positive reaction in testing. So any sample that comes to the blood bank that when they go to centrifuge it down is hemolyzed, they're going to cancel and reject and say please redraw. And of course we don't want samples that are contaminated with any IV fluids. Patient history is very, very important. So we're going to consult our previous records. We want to know their current ABO and D typing, and it must be compared with results performed over the past 12 months, and they better agree. And laboratory computer systems also have these things called delta checks where, you know, if I'm doing some testing and I enter in a different ABO type, it's going to flag it with big red flags, you know, alert, alert, change in type, okay? Previous records must also be consulted for any significant event related to testing or transfusion. So if we have a patient who maybe was in our hospital a few months ago and at that point they had a transfusion reaction, that's important information that's going to impact how we handle their testing this time around because they may have developed an antibody, and so we have to take that into consideration. So this slide has to do with testing on the donor blood. And so here is the infamous picture I alluded to earlier. So here we see clearly this is 1 unit of packed red cells. And how do I know? You see it says red blood cells, and it's telling us that they have some additives in them and that they are leukocyte reduced. And that's going to be important when we talk about processing of donor samples a little bit later. You will notice volunteer donor here in the US. No one gets paid to donate blood products that will be transfused into another person. Okay, and that's the key element. Okay, you can donate your blood for research and maybe get paid, but not when it's going to be transfused into another person. And we see all the barcodes. So as these arrive in the lab, they're going to be scanned. The unit number is going to be captured along with expiration date. And so that's kind of not information we can see on this unit, but what I can say to you is that units have varying dates of expiration depending on the additives and the anticoagulant that is used, and we'll be going over that in a future unit. Clearly, we know the ABO type is A, and this one is Rh positive. Okay, so the blood bank refrigerator is going to be organized with all of our A positive units. They have these little, like plastic stands. All the units are standing at attention, and they are going to have their stock with the ones that are going to expire first in the front, and then the ones in the back are going to be the ones that have a longer expiration date because we don't want to waste anything. When these units arrive in the hospital, they are not just placed immediately in the refrigerator. So we have to do some retyping for confirmation when the units arrive. So donor whole blood and red cells must be retyped to confirm correct ABO. And so they are not going to go into the bag. They are going to use, here they are, those segments. And so remember, this is the tubing. When the donor was being drawn, the needle's in the donor's arm and blood's flowing through all this tubing into the bag. They heat seal this tubing into segments. They're kind of like little link sausages all attached together, and each segment you can see has the unit number stamped on it. This is the same number of this unit. So they're just going to clip off one of these units, drain the red cells from that unit in a tube, and do the typing. And this unit is Rh positive. They're just going to check that it's A. They don't need to recheck D. So that's coming up to our next thing. So ABO testing is rechecked on all units. The D testing is rechecked only if it's an Rh negative unit. Okay, so if we have an Rh positive unit, no need to check the D. We're just going to check that it's A. If this were A negative, I would have to check the A and confirm that it's truly Rh negative. And hospitals don't do weak D testing. It's not required as a recheck. They're just going to confirm that that initial immediate spin testing with anti-D is negative. And so think about why that's important. We know that when we have Rh negative recipients, we ideally want to give them Rh negative red cells. Okay, and so it's really important that we double check that. These records are kept for 5 years. Okay, so remember, every unit gets their ABO type checked. We check the Rh only on the Rh negative units. So any specimens that we collect on the recipient, we're going to retain those specimens in the refrigerator for 7 days after the transfusion in case we need to go back to them and retype or retest. And we're going to see when we go over transfusion reactions why that can be important. ABO and D typing discrepancies should be resolved before transfusion. So think back to lectures 5 and 6 when we talked about discrepancies that can arise, extra reactions, missing reactions, weak reactions, etc. Okay, so we have to resolve that before the transfusion. We can't say, oh, they forward type as A and they reverse type as O. No, not good enough. It has to be one type. And we do not have to do weak D testing on the recipient. So think about it. If our recipient on forward typing comes up as D negative, no big deal. We're going to classify them as Rh negative and give them an Rh negative unit, which will not harm anyone. Okay, so even if they were weak D positive, getting an Rh negative unit is not going to hurt. When we're doing our antibody detection, our antibody screen, our reagent screening cells must be unpooled. Cross-matching, remember, it is done to demonstrate ABO incompatibility, which is oftentimes related to clerical error, and to determine clinically significant antibodies. So this slide has to do with selection of ABO donor units, and we're going to learn more about the other types of transfusion products in future lectures, but for now, we're going to do a review, okay? So here are our ABO types, A, B, AB, and O. Remember, we talked about this when we did the ABO system. When someone is getting a transfusion of whole blood, it must be their same type, no other type. Only ABO identical, okay? If you're type A, you have to get A. If you're type B, you have to get B. If you're AB, only AB. O, only O. Because remember, whole blood, you're getting red cells with antigens and also plasma that has antibodies. So please, it can only be the same exact type. We've talked about this one before as well. When someone's getting packed red cells, remember, they can always get their same type. Anyone can get O red cells because O is the universal red cell donor. So we see O is listed with each type. An individual who's AB, although they are the rarest blood type, they could receive AB, A, B, or O because remember, they have both antigens. Remember, O is the universal donor, so anyone can get that. Of course, ideally, we'd like to give them the same type, ABO identical, but if not, there are other choices in this case. And then as far as plasma, we have to reverse our thinking and think about reverse typing. Okay, so plasma, an individual is getting ABO antibodies in that plasma. So the universal plasma donor is AB. Okay, so we can see anyone can get AB plasma. You can always get your own type. When you're type AB, you can only get AB in this case, plasma, because remember, someone who's AB lacks both anti-A and anti-B, so they can only get from their own type. In this case, type O is the universal plasma recipient, okay, because O has both anti-A and anti-B, naturally occurring ABO antibodies, so they won't be harmed by getting plasma from any of the other blood groups. So I hope that makes sense. That should be a review. We've talked about this previously. Selection of donor units. Okay, so we're going to talk about D antigen. So remember, D antigen is what tells us when someone is Rh positive if they have it, and they're Rh negative if they lack it. We should only give D negative units when we have an Rh negative recipient, and we give priority to women of childbearing age and younger, okay? The reason is, think back to when we talked about the Rh blood group system. The D antigen is very immunogenic, meaning if a person is exposed to the D antigen and they lack it, there's a very good chance they could make an anti-D. This could be really critical in women of childbearing age and younger because it can have an impact on pregnancies, and we'll be looking more closely at that in an upcoming lecture. Okay, so they would get priority. D antigen negative blood should be given if anti-D antibody is present in a recipient. Okay, so why would somebody have anti-D? We have an Rh negative person who maybe got an emergency transfusion and it happened to be Rh positive red cells and they made anti-D. Well, hopefully this makes sense. If somebody has anti-D, you don't want to give them D positive red cells, because what's going to happen? Their anti-D is going to say, hey, there's my D antigen target on those donor red cells, and we're going to have an immune complex form, and there will be a transfusion reaction. Whenever we have a recipient with antibodies, we must try to provide antigen negative units for ABO, for RH, for KEL, Duffy, and KID. These are all clinically significant antibodies, and so we talked a little bit about that when we were doing our panel testing. So if my patient has antibody against big E, I want to give them ABO compatible, E antigen negative. Same thing as what we talked about here. If they have anti-E and we give them donor red cells that have the E, their anti-E is going to say, hey, there's my target. There's going to be a transfusion reaction. Okay? If my patient has anti-Duffy B, I need to give them Duffy B antigen negative red cells. We do not want to have a match in this case. We don't want that antibody to find its target on the donor red cells, because basically, remember, if that happens, those donor red cells are not going to be doing their job of raising the hemoglobin by 1 and hematocrit by 3. That's our goal, okay? So if those donor cells are destroyed, it's just going to put trauma on this patient. It's not going to help them in any respect. Tagging blood products. Once we've cross-matched a unit and we've allocated this unit for a specific recipient, that unit is tagged with a label that has the patient's full name and a second independent identifier like a hospital ID number. The name of the blood product must be on there. So, you know, we saw previously how the picture of the red cells had red cells on it. Unique donor unit number or pool number. The pool number we'll talk in more detail about later, but sometimes when individuals need transfusions of platelets or plasma, for instance, we have to combine more than one unit together. So there's a pool number that's assigned. So don't worry about that for now. Unit's expiration date and ABO and D typing. Interpretation of the cross match. Compatible, incompatible, or uncross matched. Okay. We've talked about how compatible. Everything's getting along. My cross match was good. We think everything's going to be good. When would we ever give incompatible, you might say? That's bad. And so at the beginning of this lecture, I mentioned to you guys that in some cases, in a situation where a patient really needs red cells, let's say we have a patient that has 3 or 4 antibodies, and this can happen in people that have had many transfusions. Maybe they have anti-Duffy B, maybe they have anti-Big E, maybe they have anti-JKA, and we can't find a unit that is antigen negative for all 3 of those. Maybe we can find a unit that, you know, doesn't have E antigen or Duffy B, but we can't find one that doesn't also have the JKB. I'm just making this up. We might have to give an incompatible unit in this case, but the physician would have to sign off on it if it's an emergency situation. Okay? Uncross-matched simply means that this happens a lot in emergency situations. Let's say we have a person, we're working at a trauma center, a UPenn, a Temple, an Einstein, on a weekend, and somebody comes in with a gunshot wound and they're hemorrhaging and bleeding out, and they're calling from the emergency department, send us 5 units. We need them now, stat. You may not have time to cross-match those units before you release them. However, you will retain the segments from each uncross-matched unit you release. And so although it will say uncross-matched, and they will transfuse those units, and what's the universal donor? O negative, right? Red cell donor. We would still do the cross-match testing, but it would, you know, it may not be done before we release the product, but we would still complete it, but it may not be able to be done before the patient gets the transfusions. And then ID of technologist who performed the test. So when you're at your clinical sites doing your blood bank rotation, this is a very interesting thing to see. There is a definite protocol for issuing blood products. And so basically, we start with the physician's order for how many units, okay? Intended recipients 2, independent identifiers, ABO group and D type. If it's an emergency situation, remember it's O negative. Requisition form, if it's not a stat thing, patient name and blood product that they need. Compare requisition form with the donor unit and tag. And so this is what's happening when the unit's being released to the person from the OR or the person from the ER. There's a give and take back and forth. So if I'm releasing a unit to the emergency department, they send someone up, and the emergency department is reading the patient's name and the blood product from the bag, and I'm comparing my paperwork to make sure it agrees, okay? Comparing the donor unit tag with the product label, checking the blood product's expiration date. There's a visual check of the unit itself. Is it discolored? If it doesn't look red and it looks a little brown, those cells may be just, breaking down. Is there a clot? Any kind of abnormal appearance, we would not want to release it then. Documentation of the person who's issuing the unit, that's the blood bank personnel, and the person receiving it who's going to take it, to the person who's getting the transfusion. Any other kind of special transfusion requirements, date and time of issue, and the destination. It's going to the ICU room 210, or it's going to the emergency department, or wherever it's going. Okay, so this is a give and take back and forth between the blood bank tech and the person they're releasing the product to. So there are instances where blood products may be released from the blood bank for a specific person, and that unit actually wasn't used, it wasn't needed. And sometimes this can happen in instances of the OR. Okay, so we will learn and talk a little bit more later about how when an individual is scheduled for a surgery, each hospital comes up with, oh, well, typically for this surgery, they need 5 red cell units, they need a unit of platelets, they need a unit of plasma, whatever they need. And the blood bank has to have all of this on hold for that patient and release it, okay? But maybe through the surgery, the patient did really well and they didn't need to use all of the units. Okay, let's talk about red cell units. So if the unit has been kept between the upper and lower temperature conditions for red cells, we're talking about here, 1 to 10 degrees C for red cells. If it's less than 1, that's bad. 0 degrees C, those red cells are going to freeze, and what happens to a cell when it thaws after being frozen? It lyses. More than 10 degrees is too warm for these red cells. They could degenerate, or they could actually, just start breaking down. And so usually the OR has a monitored refrigerator. And so what this means is a refrigerator that's monitored by the blood bank for temperature. So, OR uses a lot of products. So when the blood bank releases those products, they're not just sitting out, waiting to be used, they're storing them in the refrigerator. So if the unit was stored in this monitored refrigerator, it can be returned, okay, because the blood bank monitors that refrigerator, okay? If, however, maybe it's a different location, the unit was stored at room temperature, okay, here's our Cinderella time. It must be returned within 30 minutes to allow reissue. Otherwise, it's trash, okay? So let's say we release a unit at 9 a.m. If they bring that unit back at 9:31, too late, it's trash, okay? It's sad but true, okay? So it's a 30-minute time limit. If it's not stored in a monitored refrigerator, it's discarded. Okay, this next slide has to do with emergency release. So when a physician is requiring emergency release, they must sign that. The tag on the donor unit must indicate it's an emergency release, and so compatibility and or infectious disease testing maybe wasn't completed at the time of release. Patient name and identifiers, donor unit ABOD typing expiration date, but once again, the lab is going to maintain the segments from the unit to cross-match, and name of person issuing the unit. And so this is from a student last year. I had a student who actually, her son was working as a volunteer at Jane's Hospital, and she brought this form in to show me because we were talking about blood release form. And so this is showing that an individual who's going to the blood bank, a transporter, you know, the steps that they would go through, similar to what we talked about, present the release form to the blood bank tech, review the patient information on the release form with the blood bank tech, and this is going back and forth where everybody's saying the numbers back and forth, okay? Make sure the unit tag has the correct unit, sign your name, blood bank tech will complete computer functions, take a cooler, okay? And then upon arrival, hand the cooler with the blood product to nursing. So just an example of some of the steps. Okay, so maximum surgical blood order schedule is something I referred to earlier in this discussion. And so, as I mentioned to you guys before, every hospital knows if they have scheduled surgeries. There's a consortium within the hospital of physicians, of lab personnel, to come up with standardly for this type of surgery, what types of products do we need? Do we need whole blood? Do we need red cells? Do we need plasma? Do we need platelets? What have you? And how many units of each? Okay. And so basically, when surgery comes out with the schedule, you know, the lab knows, you know, how many products then to order on a weekly basis. Okay. And it can also be a guide for the number of autologous units that can be donated. So for certain types of surgeries, a physician may recommend to the patient, like, go donate a unit or two for yourself before your surgery, and that's entirely possible as well. Let's see, type and screen procedure is referred to as TNS, and so you guys may recall this from phlebotomy. When we're talking about type and screen, it includes ABO, RH, and antibody screen, and it's performed on all patients before surgeries, okay? In a non-emergent situation, cross-matching is performed on the sample later if blood is needed, and the goal of a TNS is to conserve the blood inventory. So here we see a chart from our book, type and screen request. So we do our ABOD type, we do the antibody screen, no ALO antibodies, no further testing needed. We could do an immediate spin or computer cross-match on any units that are needed on that patient. Okay. Middle, we do ABOD type. We detect an ALO antibody. Well, we got to do a panel to identify the antibody. And since this patient has a current antibody, we cannot do immediate spin cross-match or computer cross-match. We would have to do a complete antiglobulin cross-match and provide antigen negative units for the antibody. As we talked about before, if this patient has anti-big K, guess what? They need to get K antigen negative donor red cells. Last scenario, ABOD phenotype, antibody screen. There's a record of a previous ALO antibody, okay? So we want to rule out or identify any additional antibodies. We still have to do the AHG cross-match and provide antigen negative units. Guess what? If they have something new that shows up now for that and for anything previously, okay? Because those antibodies just don't go away. So let's say this person had an anti-JKB last year. We still need to give them JKB antigen negative red cells now, okay? It doesn't just disappear. So other instances that are important with cross-matching. So a couple minutes ago, we talked about how sometimes people donate units of blood for themselves. And autologous units can only be used for that person. So they cannot be transfused into anyone else. They're only for that individual and their surgery because it's not screened for infectious diseases like HIV or hepatitis or anything else. And so if that unit, let's say that a person donates 2 autologous units and only 1 is needed, the second unit would be trashed. Okay, it cannot be used for anyone else. And so there's a process to track these units so that they get to the person who they belong to. Now, this is going to be something we're going to build on when we get to HDFN, hemolytic disease of the fetus and newborn. When we have infants younger than 4 months of age, we can do our ABO-ND typing, absolutely. Only forward. We are not going to do reverse typing because let's think about it. Remember, in our very first lecture, we talked about passive immunization. Any newborn up to 4 months of age, any antibodies they have are going to be of maternal origin. Who remembers what class antibody crosses over the placenta? Hopefully you remember IgG, right? The small one. So we do not do reverse typing because oftentimes it looks like a discrepancy. We might have a type A infant with an anti-A. How could that be? It's the mother's anti-A. It doesn't usually attack their red cells, but they have these maternal antibodies. So if we're doing an antibody screen, it could be performed either on the infant or the mother, because remember, at this point, any antibodies are of maternal origin. If we do find that there is an unexpected antibody present, let's say mom has anti-big C, we're going to give the baby C antigen negative units because they have that maternal anti-C in their body through passive crossing over the placenta. Okay, so we're going to kind of wrap this up and talk a little bit about compatibility testing on other types of products. And so you just have to bear with me because we're going to talk more about these other products and how we get them and how they're stored, etc., in a later unit. Okay, but there's frozen plasma and platelet concentrates. So platelet concentrates are platelets from one donor unit. Okay, so we have an individual who donates and it's the platelets that come out of their unit. Cryoprecipitate is it's a product that's very rich in coagulation factors. None of these products need to be cross-matched, and here's why. They do not normally contain red cells. So frozen plasma, platelet concentrates, cryoprecipitate, they'll have the ABO type of the donor on there, but we don't have to cross-match them because they normally don't have any red cells present through processing. So the plasma products are going to be ABO serum compatible. Remember, what is the universal plasma donor? Anybody? It's not O. Don't give O. AB. Okay? D antigen does not affect plasma. Okay, so we want it to be ABO serum compatible, reverse typing. Think about the ABO antibodies. We don't want to give antibodies to somebody that is going to attach onto their red cells. So for instance, individual who is type AB can only get AB plasma, remember? Someone who's type O could get plasma from anybody because they have both anti-A and anti-B. Now, when there is an instance, cryoprecipitate and platelet concentrates may not even need to be ABO compatible if they're transfused in a mix along with ABO compatible units. So let's say we have a type A individual. We're giving mostly A platelets, but we need one more unit and we only have O. Give an O platelet along, that's fine. Apheresis platelets and granulocyte concentrates may need to be cross-matched if they contain, here's the key, more than 2 milliliters of red cells. So anytime a product has contamination with red cells, then we have to cross-match it because the red cells in that unit we're giving them along with the unit to the patient. And so apheresis is when an individual goes and they're hooked up to a machine, and basically all of their blood is removed sterilely, but only the platelets are removed, and the plasma, the red cells, and leukocytes are just sent back in. Okay. So a review of our compatibility testing steps. We want accurate patient recipient identification, okay, proper sample collection, labeling, and handling. The blood bank's going to review to see if we have previous records. We do ABO and D, antibody screen on all donor units by our blood donor center. ABO-D phenotyping and antibody screen on our recipient, that's our type and screen, and then we can cross-match the recipient with any units we're thinking of giving them. If recipient possesses a clinically significant antibody, we must provide donor units that are negative for the antigen. And remember that testing to determine what antigens are present on the donor unit red cells in this case is called phenotyping. I don't know why that big long line went up there. I'm sorry about that. Okay, this is called phenotyping. Okay, and we're going to have to screen. We need A negative units. We're going to have to antigen type a couple A negative units to find some that are negative for the antigen that we need. Tagging, inspecting, and issuing blood products. Remember, it's a whole protocol that goes back and forth of issuing the blood products between the person taking it to the patient and the blood bank personnel. They will always re-identify the recipient before transfusion. We'll be talking about details transfusion protocol in a future unit. And they will carefully observe that recipient's vital signs every 15 minutes, basically during the transfusion, to make sure they are not having a transfusion reaction. Okay, so I think we looked at this already. It looks very similar to the one we looked at previously. Yeah, we did. It's a dupe. Okay. Patient blood management. Okay, it's an approach to reduce or eliminate anemia and the need for allogenic transfusions, meaning getting a transfusion with products from someone else. Tries to manage anemia or bleeding risk prior to surgery. So basically, for instance, here's something that we talked about in hematology. People that may have an anemia, rather than getting a transfusion, or they may get a dose of erythropoietin to stimulate their own body to make more red cells. These days, there are a lot of intraoperative techniques to recover blood during surgery. So what does that mean? There is a sterile way during surgery to collect some of the blood that's lost from the patient into these sterile drains, and then their own blood is reinfused back into them at the end of the surgery. And so this basically reduces the risk to the patient and reduces costs. And so what we have to keep in mind is that there are some people who, due to religious beliefs, do not want to have a transfusion of blood from another person. And so, some of these techniques to recover their own blood, or, have an autologous unit collected prior to their surgery, can maybe be good in certain instances. And that will finish it. Okay. So I will say goodbye for now, and I will talk to you guys at a future time.